So, ladies and gentlemen, Honorable Minister, Ambassador, thank you for joining us for this event, lunch event today during the WHA. It's one of the many events we are organizing, and of course, the rain outside doesn't help to bring the people in the room. But I'm very pleased to have you all here and that you're interested actually in health and all policies and in the approach different countries take and have a discussion around that. I think it is an important topic which we want to also embed a little bit in the wider discussion around governance, of course, which is our focus as Global Health Centre here at the Credit Institute. But of course, HiAP is also really about alignment of different interests. It's about intersecting and working with different actors, government actors and outside actors, and in that sense it is actually a difficult approach to take on how can that be done. And we are really interested in that and learn from the different countries here. We have got some really excellent panelists, Honorable Minister also who has invited actually also for this event. And so I'm very pleased actually without much ado to start this event and also hope to have your engagement and your participation. So we will open also for Q&A at some point. So Honorable Minister, if I would please ask you to give some opening remarks. I mean, Sudan has been really also a champion in that, has taken that forward at the different sessions, has worked at the country level, and we will hear also a bit later. And of course, you have been also the one who initiated last year and launched the global network for HiAP. So we are also here as different members, and we hope that we get some more members interested in our network. Honorable Minister, please, the floor is yours.
Honorable colleague ministers, honorable delegates, members of the Global Network for Health and All Policies, dear guests, it is my pleasure to welcome you all to this side event for Health and All Policies. A strategic function of the public health and universal health coverage, which she organized under the umbrella of the Global Network for Health and All Policies. I would especially like to thank the governments of Quebec, Canada, Namibia, Somalia, and Finland for co-sponsoring this event, along with the Republic of Sudan. I would also like to express my gratitude for the Global Health Centre at the Gratitude Institute for hosting this side event for the second time, respectively. As the World Health Organization celebrating its 70th anniversary, the Health and All Policies event will align with the 70th anniversary celebration theme, which is Health for All, Commit Universal Health Coverage. Really, we believe that the objectives of the Health and All Policies, objectives of the Universal Health Coverage, and the Sustainable Development Goals cannot be achieved unless you take the Health and All Policies aligned with it. So this is why we said it that at the time we are organizing this Health and All Policies, also we are celebrating the 70th anniversary with the theme of Health for All and Commit for the Universal Health Coverage. I would like to commence my speech by giving a brief introduction to the Global Network for Health and All Policies, emphasizing on its background and the main objective behind its initiative. The Global Network for Health and All Policies is a global initiative embarked on initially be a group of countries in order to institutionalize and facilitate the implementation of the Health and All Policies approach worldwide. The seed of the network was planted in a side event during the 19th World Health Assembly in Geneva, named Health and All Policies for Sustainable Development Goals Achievement, which was hosted by the Federal Ministry of the Health of the Republic of Sudan in coordination with the Ministries of the Health of Thailand and Finland. This event led to the launch of the network a year after, during the 70th World Health Assembly in Geneva in May 2017. The primary motivation behind this initiative was that countries were struggling to achieve Millennium Development Goals prior to 2015, and they are also still struggling to achieve the Sustainable Development Goals. It is evident that addressing social determinants of health and health inequalities requires an intersectoral approach, and that no health sector can implement universal health coverage without a well-established and essential public health functions. We all know that change cannot take place without the commitment of governments. And so the commitment, coordination, collaboration, and partnership between the different sectors and the Ministry of Health, it is almost impossible to move progressively towards the Sustainable Development Goals and the universal health coverage. We believe that Health in All Policies approach facilitates that commitment. With the vision of creating a global platform to strengthen and advance Health in All Policies approach and to progress towards Sustainable Development Goals and universal health coverage, several objectives have been set for the Global Network for Health in All Policies, which are: number one, to advocate for health in all policies; number two, to lead, provide, and facilitate health in all policies implementation in regions, national, and subnational levels to support the implementation of the SDGs agenda; number three, to strengthen and institutionalize health in all policies as a whole of government approach; number four, to facilitate the development of tools, guidelines, and to support step-by-step health in all policy implementation from the theory to practice, with the benefit of worldwide expertise in collaboration with WHO and other partners. Number five, to enable knowledge sharing and learning from the country experiences, reflecting cultural diversity and context through the South-South and triangular cooperation. Number six, to enhance the research and evidence generation on the effectiveness of the health in all policies approach to support the implementation of the SDGs and the health and the universal health coverage. Number seven, to create an online platform where countries can access a range of support materials, engage in rich interactive discussions, and share experiences. Lastly, to build capacity and skills to enable implementation of health in all policies, facilitate system change towards embedded sustainable development. There are now concrete experiences for a range of low, middle, and high-income countries on how to implement the health in all policies approach, as well as how to overcome bottlenecks facing its implementation. This event will collectively address ways to close gaps in knowledge on health in all policies and the way forward to reach Sustainable Development Goals and universal health coverage through sharing international experiences applying health in all policies, capturing critical success factors which underpin health in all policies approach, and sharing the preliminary results of the Health in All Policies Global Survey. I would like to emphasize again on my sincere appreciation for the sponsors of the event, as well as the members of the network, which is special thanks to the members of the steering committee and the executive committee for extraordinary efforts and dedication they have been put in this initiative. And finally, on behalf of the steering committee of the Global Health in All Policies, I would like to welcome you all for this side event, and a special thanks to Michaela for moderating this side event. Thank you so much.
Thank you, Minister. Thank you, Minister, for these really in-depth reflections also about HiAP, but also locating it within the UHC approach, which of course is the overarching theme of this World Health Assembly, and linking it back to population health. We want to transform population health, we want to change, we want to have an impact with HiAP, and through actions on the determinants of health. And of course, we have a wide range of determinants here, and we want to also hear on how different countries do that. So there are champions, yes, we have heard that. We want to also share knowledge and experiences through the country experiences. And so for that purpose, then, I would like to call on my panelists to come on the stage. So if I may call on Virasek Puttasri, Deputy Secretary General of the National Health Commission Office from Thailand, please. Take your seat. Yes, I'll take you in the order. Maria Nera, please, if I may ask you to come to the stage, who is the Director of the Department of Public Health, Environment and Social Determinants of Health of WHO. Thank you for joining us today. Horacia Ruda, who is the Chief Public Health Officer and Assistant Deputy Minister of the Government of Quebec, Canada. Thank you for coming. Taro Koivisto, please, if you would take your seat, Underpanel Director of the Department of Wellbeing and Health of the Ministry of Social Affairs and Health from Finland. And finally, Dr. Abdallah Osman, please, if you would join us as well, Director of the National Institute for Public Health of Sudan. So thank you very much for joining us. So we have here actually really a wide range of different experiences across the world, I would say. We managed a gender balance, more or less. If you include me, then we are very balanced. But let me also now come back a little bit to the discussions of today. So what we want to really focus on is around the different coordination mechanisms. We have heard that you need to interact with different actors, with the different sectors. It's actually essential. We also know that actually from the different declarations, I mean, Finland has hosted the AIDS Global Conference on Health Promotion and also has asked for a framework for action. The Helsinki statement is a framework for action on country level, asked for that specifically. Of course, we also had then followed that the 9th Global Conference with the Shanghai Declaration, which also links it to the different, SDGs and says we need to interact, we need to look at all the SDGs, we need to act with different actors, we need a whole of society approach, which was emphasized then as well. But we also need political choices, we need political commitment. And we have heard that also from the minister, that commitment is so important in order if you want to achieve that change. So let me then start with Finland. You have hosted that conference, you have been a champion here for many years. You also actually pointed out that political commitment as well and trust, which is so important. So tell us a little bit on how have you been able to actually, what is your mechanism to coordinate?
Thank you so much for this opportunity to speak about our experiences. To start with, Sustainable Development Goals, which just now are high priority, we are really happy to, as was mentioned in the opening, to have this health in all policies approach, which is supporting very much to implement these all the targets of Sustainable Development Goals, and especially it's such an opportunity for us because it creates us an opportunity to find partners also from other sectors. So we can use health in all policies as a tool there, because it's not just a tool but an approach, and we try to do that also in Finland. But as you asked about what we have done and what are our governance structures, we have found for a long time ago that we need something permanent. Structures, processes, tools, and that's essential. If you just have projects and some kind of programs, you don't achieve so much because they are ending, financing is ending, etc. But if you have something which is permanent, it creates opportunities to find partners always when it comes up some other new challenges or some tasks you have to take forward. And that's something which we have very much have as a basis for all activities. The concept of health in all policies was launched in 2006 when Finland followed its EU presidency. And at that time we had to create some mechanisms how we prepare for all issues which are dealt with in EU. So we created committees and working groups which are multi-sectoral already then, so that we could all sectors together nationally prepare for these statements and our positions for EU. So that was the basis for this term. But of course we have a long time before that already worked multi-sectorally. So that was the birth of a concept. But I would like to start from a level of municipalities, local level in Finland. That's something which I think we are really successful and a good example. Perhaps national level is not so good example, but municipalities have been a forerunner of health in all policies approach and all the governance structures where, of course, we have initiated it from national level because we have created a legislation for that, because we have law on which this is based. So it's a legal obligation for municipalities and local level since 2010. And there are really good practices to work across sectors. So the municipalities in practice are creating, or they have to have a multi-sectoral groups for health and well-being. So health and well-being, not just health, both of these are included there. And these groups take care of concrete duties and tasks, operational management, planning, implementation, evaluation, everything there in the local level. And in these groups there are all different sectors from municipality represented, not just health sector. So, because in municipality there are all education, physical activity, environment, planning, etc. All these are working together for the well-being and health of the population or residents of a municipality. Then another duty of a municipality is to monitor the trends of health and well-being of residents by population groups and also factors which are affecting them. And then they have to prepare a well-being report every 4 years and present this to the politicians. So the politicians also know what's the situation and what are the consequences, what they have been doing. Another example about the duties of municipality is human impact assessment, which is also by law a duty of municipalities. They have to evaluate or assess beforehand what are the consequences of a decision, so the politicians know what they are doing, so what are they deciding. So all these are somehow connected and as a part of administration and all these activities in the municipality and really working well. Of course, there's a lot of challenges. For example, this human impact assessment, it's not so easy to implement. We need to create some more tools and support for municipalities, but however, these are there in place. And politicians also and high-level civil servants have found that these are useful. These are not just something up there, but something which is practical and supporting the activities. But then coming back to the national level, we are drafting laws and creating the circumstances for the local level and all activities there, but we could do better, I have to say. So that this impact assessment, it's a duty of all the drafting of laws in Finland, but it's not very well, not yet. We have to improve that still, but it's a duty in Finland. We have to make these assessments when we are drafting legislation. we have different kind of other committees as well. I mentioned the EU issues, but other multi-sectoral committees which are working on national level. And we have rather good cooperation between the ministries, but there are, just now we don't have, for example, any public health committee or such organ which works on general issues on health and well-being. But there are several, for example, for nutrition. And one good example is One Health issue, which we are very good in implementation. So we are working with the Ministry of Environment, Ministry of Agriculture, and together, for example, AMR issues are dealt together. And also health security, there are all ministries together working. So we are nowadays very much creating these kind of structures for around some broad subjects which are common for everyone. So it's easier to have a grassroots and very practical approach, not general level discussions, but more practical. And of course, we try to forward it also to the international level activities and try to have it there. But just such kind of experiences from Finland.
Thank you, Taro. Can I just ask a follow-up question here? Because you mentioned we can improve. So I am very tempted to ask you here then, what is your biggest challenge then at the national level, as you have mentioned that?
We have good cooperation with most of the ministries. And it's a challenge is cooperation with the Ministry of Finance. But I have to say that it has improved rather much during the last years. Some years ago, we didn't have anything common. They just said that we are just making expenses and we are not very useful. But nowadays, we are just now drafting a new big package of legislation to reform our whole health and social care system and also regional government system. And that's a big reform which we are together doing with the Ministry of Finance. And now we have found what's common for us. So they understand more about the substance, about the services, and especially they are nowadays much more aware of what the importance is there for the health and well-being of people. It's just not a cost, it's an asset. And that's something, while we found something which is our common task, it created an opportunity also to understand each other better.
Thank you, Taro. Thank you for being so open here, because and also to mention the Minister of Finance, because I think that ministry is, of course, crucial if you talk about HiAP, and it is a challenge because you need to find a common denominator in terms of an understanding, creating an understanding of speaking also the same language, and understanding there for each other. And I think it's really interesting because we had that same discussion also at our discussion yesterday around AMR, where one of the challenges was precisely that as well, about creating a common language. And I think it is something really in common when once you go out of your silo and work with different sectors. So thank you for alluding to that, but also thank you for bringing in that whole notion of municipalities and the importance of municipalities, because I think cities nowadays do play really an important role. And we need to work with them. They can make actually the real change at the population level. That's what we want. So that's their acting. They can enact as well. But it's very interesting that you actually have a legislation at that level. And with that, I also want to now turn to Virasek, actually, and just to mention to all of you that we do have here little bios. So therefore, I'm not introducing everybody and all their vast history and experience, so please do read up the bios you find in the booklet. But Virasek, you're from Thailand and you also have a law.
Yeah.
You have the National Health Act, which was actually passed in 2007, and you have a National Health Assembly. So how does it work with you? You have a law at the national level.
Yeah.
Please.
Okay, thank you. Thank you. Before the act or the law, I would like to brief you some information of the Thai health system reform first to understand what the context of Thailand. A decade of health system reform in Thailand, they changed the system governance from the vertical governance by the minister or something, change to the partnership, governance by partnership. Why I say that? Because there are new independent agency who taking law of the health, increasing number of the agency. There are Thailand Health Foundation, Thai Health Foundation, who finance from the sin tax, from the alcohol and tobacco tax, take care of the health promotion, as well as the social determinants of health, something like that. There are the Health System Research Institute who taking care of the evidence base for the policy making, evidence-based policy making. There are something like that. And we have the agency who create or who create the evidence international health policy program for the health system and policy research, something like that. And another agency is National Health Security Office, act like the purchaser of the Universal Health Coverage, something like that. The relationship is changed from 10 years, from the vertical to the partnership. There are the active role of the private as well. A quarter of the hospital beds in Thailand belonging to the private one. There are active role of the consumer protection group, the media, and as well as the health professional as well. In the National Health Act 2007, there are three things that why we change the system. The first one is the definition of health. It's the broadening of the definitions. Not only health itself, but it's explained to the physical health, mental health, social health, spiritual health as well. Anything about health. That's why we include everybody in the floor already. And as well as the social determinant of health that we taking care. The second one is according to the law, we have the National Health Commissions chaired by the Prime Minister. And the committee, combination of the committee come from the government sector, come from the knowledge sector, and civil society sector that we call the triangle. They propose the policy related to the health to the cabinet for the consideration or the approval. It depends on the issue. The third one that the act create the platform or the tools of the participation. Health assembly that you already mentioned. We have health charter. It's agreement of the health or principle of the health that we agree together. Health impact assessment too, something like that. Is create the participation by these two. The last one is our office, my office, National Health Commission Office, is a coordination function, coordination unit of the participations. We use the soft power, not hard power. Soft power is mean we discuss together and engage, they commit yourself to do something like that. So we need the encourage the people to participate in, empower them. Not only the encourage, but to empower. The last one is try to create the environment for the open the society for the discussion. That I would like to explain for that. Thank you.
Thank you, Virasek. And maybe here also, I mean, really interesting that both of you actually have stressed the definition of health. Yeah. So, you know, health and well-being, really well-being also as part with Finland, as well as the very even broader definition which you apply in Thailand. I think that's really important, especially as you link it to the determinants of health. But then also, as you talked, you actually mentioned the National Health Assembly, and I really want to follow up on that a little bit, because I think it is a really interesting concept where you actually try to get citizen engagement. And let me ask you here a difficult question. You're talking here about soft power, and you talk about empowerment of actors. Yes. So how do you deal with the private sector?
The private sector? Yeah. Oh, actually, all sector in Thailand is try to encourage this one. I would like to give you an example of the private ones. The private one, they want to, there are many issues of the health from the private. For instance, for the chemical use in the agriculture or even in the living daily, something like that. And the private, they would like to integrate their health service to the health system service as a whole, something like this. And there are many social determinants. It come from the private. We already discussed with the free trade agreement, the agreement between in the region or something like that. It might affect health. Something that we have tax of the alcohol, tax of the tobacco, something like that. It depends on the agreement of the free trade. That's why the civil society and the private quite active for this one. I think it's because the definition of health maybe is quiet, and they need the participation. They need friends. They need somebody to discuss, and we have the agreement and to do something together. That the private one. Unfortunately, for me myself, I would like to reflect of the partnership from the government sector. Actually, the government sector, they are using the power of the vertical, right? The SME maybe they are less interested in this one, but sometimes they need participation. For instance, the Ministry of Health, they propose the physical activity, because the physical activity not only the policy, but they try to encourage everybody to participate in. They use the SMB as the tool for that one. The Ministry of Health use the assembly for the policy of dengue fever control, because it depends on the household behavior or something like that. And for me, it's the civil society is quite active. It's quite active. They're quite active in propose the agenda. They're quite active in the engage in the policy, engage in the resolution and decision process, as well as the implementation. That I think there's a challenge of the partnership. We have to, it's quite a challenge, even though we have a decade of the assembly as well. That's the challenge for Thailand now.
Thank you. But at the same time, that citizen engagement really is also a citizen engagement, although you have a structure there, it's really also for action. Yeah. So it's not just a structure, it is for a purpose. Yeah. So it is for the purpose of engagement and for implementation. So with that, let me move to Canada. Horacio, I mean, Canada is a federal state, government of Quebec, so you're very particular here. Yeah, sits among member states. Quebec is not quite yet a member state, but a government in itself, as you're organized in a very different level. So tell us, how does it actually then look for you? I mean, how do you manage, yeah, at the provincial level, so to speak, be federal? Yeah, how does that impact? Are there magic solutions?
Is it working? Okay, thank you. Thanks for the invitation. First of all, I would like to make a comment about health in all policy approach, and I would say universal health coverage. Canada has a good health coverage system, even Quebec too. But with the demographic changes, with the chronic disease like diabetes that are preventable, really well, like there is now diabetes type 2 on children, which was not existing when I did my medical school. The system could not sustain with medical treatments, and so if we don't make prevention, we're going to be in problem. We're going to even make at risk our universal health coverage. So it's why it's very important to do that. And the health is also a power of a country. Our economy is less in petroleum and mines. It's on brain of our people. So if we have good people in good health, the country goes better. So other sectors are understanding that health is important. And also we understand that health is not the system of health which is the best determinant. It's on the social determinant of health. So in Quebec, in Canada, the health sector is the responsibility of the provinces. So it's why we can have this approach. We launched in 2016 our first health in all policy approach in the government with 15 ministries and I would say other organizations. So it was a commitment at the highest level from the Prime Minister and 15 ministries. We made a year after an action plan that we are implementing. But I think what is very important is to keep that plan, to implement it till the local level where municipalities are the nearest government who can make some decisions on environmental places, on transport, on exercising. So it's very important to have those, I would say, orientations from the national, but also implementing it locally. And what is important is to keep the machine of the government and the politic committed in the same way, because it's the politicians who's going to take the investments, who will take the orientations, and there is elections every 4 years in Quebec. So one of my nightmares is to make sure, because it takes not only 1 year to implement, to change a culture of a government who works on silos, to have a broader aspect, is how to make sure that the next government, even if it's a completely different type of approach, will understand that. So it's why we want at the same time to have a high-level committee with the Prime Minister and the 15 ministers, but also have all the machine, the associated deputy ministers, the deputy ministers involved in this approach. Like our next elections will be in October, and I'm going to work with my colleagues of the 15 ministries to brief the new ministers, if it's a new ministers, if it's not the same government, if it's the same, it's going to be easy. But even there is some change, to keep that commitment, which is very important. And also to have the finance people with us. We've got 20 million per year for this thing, but I think we're going to need more for that. So the governance is always to make sure that people really well understand. And as you told, it's not a vertical approach, it's a more win-win situation. How can I help family ministry? How can I help education ministry and their own policies? And in fact, health in all policies is like an umbrella on different strategies everybody does. But it makes more coherence, it makes things go in the same side, not, I would say, deviating an action from one ministry to another one. And and it's very important also to reduce health inequities in between groups, because we've got also in health inequities even in very rich countries. So I think there is very importance to make that political will. And another way is also to have some tables, and we do have some tables by sectors, with partners, with ONGs, with population, with leaders. Like we have an Olympic girl, she was a diving gold medal, who's now working on a good lifestyle. She's a leader, and we have those persons with us, making some pressure on the government, because governments will answer to pressure of the personality. So people must understand the importance of those approaches. So it's why we want to have also some tables for healthy living, others for nutrition, with partners in relation with the associated deputy minister at the high level. That's the challenge, and I can say 5 or 6 years from now, if we did some succeed, because we just launched that 2 years ago. And we want to make sure, and we got some, I would say, targets, 9 targets to follow up, and indicators to see if there is this change. But that's a cultural change in governments. You know, you never must take into account that everybody understand. People are changing, ministers are changing, and they must understand how this health in all policies is a win-win situation for their own budget and for their own projects.
Thank you, Horacio, because also you stress so much also the political will which we need here. And of course, we need the political will, but at the same time, you also mentioned we need a change of culture, because we need continuity. And that only works actually if you create a different culture where you engage. Now, you have an impressive record here with 15 ministries being involved here. So let me ask you and come back to the challenge Taro has mentioned at the beginning. How do you work with the Minister of Finance? Is that an easy go?
Is part of some of his people is part of the team, and he understands also that if we want to sustain the system, We know in Quebec we have social services and health together is 52% of the budget of the government. It's a lot of money. So, and if we want to keep our system alive, if we don't do prevention, the costs are always going to go up. So it sees some advantage to work in prevention. And the other sectors like education, it's not to change their mission, but it's to make them understand how health and how they can influence a determinant that will have a lot of impact on health. Because if we continue to put money on care and care and care and care, which could be enormous, we won't do the right things of primary prevention, of population health, of education that is needed. Even I would say education is more important than the health sector if you want a good population with literacy to understand what to do. Knowing how to cook, because people now are eating things which are not good for the health and don't know how to cook anymore. So that's all that kind of aspect. So finance is understanding what we are doing, but we also have to prove that we get some success, like tobacco reduction levels and everything. So I think they understand it, and they understand that we have no choice anymore. If we don't go that way, we're going to have a bigger risk of private and having, I would say, rich people who are going to get access to care and the poor ones no more access. So it's incredible. And even, I would say, there is an issue with manpower, where people to work, actually. And if we don't take care of our people working, the costs of insurance are going very high, not only for physical diseases, but all kinds of, I would say, mental health issues. So that's part of the solution. I think prevention is part of the solution and part of the control of the costs of the system.
So it's really also to understand the economic impact, and that health is an economic force, ultimately, and that maybe speaks then the language of those who need to hear that and therefore act upon it. But of course you also mentioned
they don't spend money when they put that in prevention, they invest.
Exactly. So you do the investment case.
That's not spending money, that's an investment.
Exactly. So it is an investment. So an investment also by Sudan, I think, into health. We also heard from Virasek that the Prime Minister is involved here at the highest level in terms of the National Health Commission, chairing the National Health Commission. Political leadership is, of course, important as well, to make the right choices, to make the right investments as well. Abdallah, can you tell us a little bit more about Sudan and how you are actually managing these different actors, the different interests also?
Thank you. Thank you for the opportunity. In Sudan, we have started with developing a roadmap for going through to health and all policy. And this roadmap has started with extensive dialogue with the different partners and different sectors, including the civil society and the private sector. And we think that this dialogue has paved the way for working together. And the dialogue has been at different levels, at levels of ministers, at levels of undersecretaries, and at levels of focal points in the different sectors. One of the important pillars which has been identified is the governance structures. And the governance is, in Sudan is going both vertically and horizontally. There is a parliament which is supposed, according to the roadmap, to receive a health report, not a health care report, a health report regularly. And this under the parliament, there is a National Health Council. The National Health Council is issued by the president, but it is already in the law, the public health law. The National Health Council is composed of the different ministries and the governors of the states. So it goes horizontally and it goes also vertically in coordinating different activities. It is chaired by the president and now chaired by the vice president because there are some changes which took place recently. Then there is a ministerial high-level forum which is headed by the minister, and in this forum there are the sectors, but the civil society and the private sector are represented. And then down, when we go down, there are the same structures at the state level. There are technical bodies which are connected to all this so that they do the technical work and they present it to the higher level. There is a public health institute which has been assigned to generate evidence, to produce the health report, and to monitor the whole process of the health and all policies. So this is the structure. Now, concerning functionality of this structure, at the national level, it is working well because there are regular meetings by the National Health Council, and there are also regular meetings by the high level of the which is headed and chaired by the minister. A lot of groundwork is taking place in the Public Health Institute and at the technical committees. At state levels, it is picking up. It is not complete in all states, but it is picking up. In some states, the Walis took the initiative and started operating the structures, and very few, maybe one or two, at the very local level also started to do the same. So we think overall there is a momentum going on, moving along these lines, the vertical and the horizontal lines. There are some issues which has been identified, and some work has started working on doing at that level. That, for example, you have nutrition, malnutrition, one of the very important issues which has been identified as a challenge in Sudan. And the Ministry of Health is working with the Ministry of Agriculture. There is a lot of work going on between the Ministry of Health and Ministry of Social Affairs and Ministry of Education also at the same time. So these activities are going here and there, but we think, generally speaking, there is a momentum and move forward. Thank you.
Thank you, Abdallah. And I'm really intrigued here because if you have listened carefully, so Tao has mentioned, some challenges at the national level, and really the municipality works really well. And here we hear the national level works really well, but yeah, there's momentum where, the other levels are picking up. So can I just ask you that follow-up question then? If you want that implementation at the municipality level, at that local level, or at the provincial level, state level in your case, what would need it? What kind of push does it need to kind of get it a further, implementation round, so to speak? So what are the challenges there?
I think the most important thing is that the functionality of the national level is very important, because here where the policy is done, according to the Sudan constitution, especially in some areas, there is the policy is a concurrent power between the federal and state levels. So there should be a very clear guidance from the national level stating policies, so that what is going to be done at the state level and at the locality level is clear from the start. So that is important. That is why I see the functionality as a national level is very important, and in the context of Sudan, in the federal system in Sudan. I think the health and all policy itself as a notion is not clearly understood at the local level. And that is what we need, a lot of advocacy, so that we go to the local level, that they can understand exactly what we mean by health and all policy. I'm quite sure that there are some activities which are health and all policies, which are not named as health and all policy, but they are health and all policies, when you go and explain, then they are not going to start from scratch. They are going definitely to start from their own experiences, which is really health and all policy. I think advocacy and communication will be a very important issue.
Thank you so much. So we have heard now from different countries, experiences, and last not least, Maria Nera. I apologize for being last, but at the same time, I did want to get the country's experiences first. It's also your chance to reflect on what you have heard, but also on your experiences. I mean, you are the director of the Department of Public Health, Environmental and Social Determinants of Health. Of course, we have also other determinants, commercial and political determinants of health, cultural, behavioral determinants, and many more. But if you reflect upon that a little bit, there is also a global strategy which is coming forward, a draft of a global strategy on environment, on health, environment, and climate change. How do you see that interlinkages? Can we learn something for here? What is your vision here? Please, the floor is yours.
So many things to say, Michaela. Let me start, and where can I start? You know, a few years ago, if you were going and thinking into going into business, the business community will tell you you need to speak English if you go on business. If you want to go on global health, you need to speak health in all policies languages. And not everybody speaks health in all policies, even among our own community. So this will be my first message. We need to make sure that everybody who pretends to have a role on global health needs to speak health in all languages. The good news is that some people speak already health in all policies without knowing it, like the mayors, the municipalities, local governments. Most of them, they do it by intuition because they understand about this interest and need to work on intersectorial policies. They don't realize that this has already been invented and is called health in all policies. But doesn't matter. The good thing is that they are doing it. And those municipalities, local governments, and mayors, they are one of the most powerful ministers of health we have at the moment. No offense, real ministers of health. You're extremely important. Please don't get me wrong. You're extremely important. But be aware that at the local level, at the city level, there are very powerful health in all policies actors that we can use if we want to mobilize health in all policies and global health. Very quickly, Michaela, if we look at what determines our health today, 70% of the global population will be living in cities in less than 20 years from now. This determines our health. I mean, how can you pretend not to be involved on how our cities, our urban spaces will be planned, developed, and designed? If we want to talk about global health, we need to influence that process. What determines our health? The quality of the air we breathe. Well, look at that. 7 million people is now dying every year prematurely because they are breathing air that is not following the recommendations of WHO. That's not the point. The point is that they breathe polluted air. So this is extremely damaging for our health, and is something that conditions our health, which is related to the sources of energy. The type of energy sources that a government will be deciding to go for it, that will condition the health of the people so dramatically. Access to safe water, access to sanitation, the transport, the way we will be commuting, moving, the type of public transport we have will be conditioning our health. The condition, the social conditions, the inequities, that will condition enormously our health. So, and of course, the care, the hospitals, the facilities, we have to take care of the people that is already sick. But if you look at the chemicals we use, the way we produce, we consume, we recycle, this will condition our health. So there is no way to afford not to speak health in all policies, because then we are out of business. If we look at, let's take just the 3 examples. Antimicrobial resistance, non-communicable diseases, and particularly diabetes, as you were mentioning, and air pollution. I mean, take the 3 of them. Unless you speak health in all policies language, unless you go and you talk to the different sectors. While we were talking, and by the way, I fully agree with all what you say, 100%, I was thinking on what I have been doing in the last 2 months. on my professional life as representative of WHO. I've been attending meetings on sustainable energy, and I saw one of the participants at the meeting in Lisbon recently, where the decisions are taken on how to increase access to clean energy at the household level. I've been attending meetings on transport, sustainable transport, public transport. I've been attending meetings where we were talking about inequities, social determinants, education, gender issues. So at the end of the day, I realized that I've been spending almost all my time talking to sectors that are influencing the health of the people. So I think I speak a little bit of health in all policies. And I know that you didn't ask me about my experience with the Ministry of Finance, but I will give it to you anyway. Because I've been Vice Minister of Health as well in my own country. I am not giving the name. Very easy to find out. And on my first year as Vice Minister, I was responsible for a national plan on prevention of obesity and physical activity and nutrition. So I went to see the Ministry of Finance for the budget. And we have a meeting with a lot of people, technical and whatever. He received me very friendly, but with a joke. And I didn't like the joke at all, because he says, okay, here's the health people. How much are you going to cost me this time? Because obviously, for a Ministry of Finance, the health sector represents cost. So I say, Minister, I have a call for you and a request. He says, already? And I say, no, it's not about money. Can we postpone this meeting 1 week? He says, why? I say, give me 1 week. So I came back 1 week later and say, Minister, I'm coming here to tell you how much we are helping you to save your horrible money. And then I gave him plenty of the win-win strategies that you were saying. You are paying now all the diabetes treatment. You are paying now for this. You are paying for that. I am proposing you a strategy to reduce that cost. If you are smart, you take it. So he had only one option, take it, because otherwise he would not be smart. So that was, you know. So I think this is, and to finalize, Micaela, a beautiful example of something that happened yesterday. Yesterday evening, I have received an email from DEFRA, which is the Department of Environment and Agriculture and Forestry in the UK. This is following, obviously, a lot of discussions. UK is about to change their government policy about air quality. They are jumping on following WHO's recommendations on the PM 2.5 means, and this is beautiful. This is the result. It was not the Ministry of Health. Of course, we have been talking with all of these people. So a decision taken by the Ministry of Agriculture, Forestry, and Environment will have an incredible impact in our lands and our brain. So I think this is health in all policies. Probably she speaks health in all policies, but she doesn't know.
Thank you, Marianne. Thank you so much. So you took my follow-up question away. I could, of course, ask you further around your experiences with precisely these other ministries, but just also to point it out how important Ministry of Environment and Agriculture is, or transportation is really important. In the sake of time also, because I'm realizing I do want to open up for you, and we have still some little input also from Carmel. I do want to open up right now. So, Marianne, my apologies. No follow-up questions. You have been quite comprehensive. But also it's a call to read the bios. So you get to find out also which countries it would have been. But let me come back to you. So who wants to ask the first question? I will bring them all together and then let you pick and indicate to me which ones you know, if you want to speak. Yeah? Okay, here in the back. Any other questions? Yeah, here, 1, 2, 3. Any ladies? We have 3 men here. Oh, okay.
Hello, thank you very much. For your discussion and the examples you presented. My name is Jorge, I'm a medical student from Portugal. My question is for Tario Covisto. I'm a really enthusiastic supporter of universal basic income, and I've been looking into some things that were tried in Finland, regarding the long-term unemployed. And I was wondering if you have some data on the impact of a universal basic income in health, because I think not necessarily universal basic income, but I think when we are discussing this health in all policies approach, we should also include some innovation in the way we see our social networks, our safety networks, and the way we, as state, provide support for those who need it the most. Thank you.
Thank you. So have here the second.
Good morning. My name is Burema. I work with Maria, so I learn a little bit from her. But I have been struggling with the issue of health in all policies, and my question is to all panelists. I think the colleague from Sudan said that people at the local level do not understand the value or the concept of health in all policy. I will say maybe it's the opposite. Communities do understand if we explain. Leaders, as Maria said, have problem to understand. Second, and I think the colleague from Canada said, we need to see this as an investment, not as Maria said, something as that is just money that is taken away from the public finances. I have been struggling with this because I work at country level and I work at the regional level. I have one approach when we were discussing and we talk about diabetes, talking about primary prevention. We use a simple concept, using diet and physical activity as an entry point to NCD prevention and control. I was told in one of the countries that they think the better person to run this is not people from health, must be either people from the education sector or the agriculture sector. So my question to you, Mr. Putersi, is do we think that we are using an approach that not is adequate? What I mean, for us to be struggling years after years for something that we know is fundamental to the health of people, but people having difficulties really to embark with us. Are we having a wrong anchorage, meaning that has to be run by the Ministry of Health, but maybe others, to bring together both the public and private sector and also non-state actors? My last question actually is the paradigm of the change. Change is always very complicated. But when we talk about the concept of health in all policy, and I like the idea of Prime Minister bring all ministers together. But if he brings all the ministers together, and if really is not taking off the way we want it, it means that something is wrong. So are we doing what we need to do to find what really is going wrong that people will not embark with us? Okay. Canada is a developed country, but in developing countries, it's a challenge because when you want to talk about health in all policies in developing countries, we need really to find what are the best way to have these things take off.
I think it's a challenge across the world, actually. Never mind the country where you're sitting in. Can I ask you, here in the back, please just be short and just your question, and I'll take another of the ladies as well. I have 1, 2 here.
Thank you. My name is Dr. Sam Lee. I work with the Department of Health of Hong Kong. A question about our honorable representative from the ministry. What are your experience in motivating the early and middle career professionals, not just in health, but also in other sectors, in health in all policy, to speak the language of health in all policy? And how do you envision your global network, which is really excellent, to influence other countries to join your effort? I'm saying this is because for students, we can always teach health in all policy in the curriculum, and our bosses, high-level officials, they can always attend the meetings. But sometimes I think it's the early and the middle stage of professional that is left behind. What do you think about this? Thank you.
Thank you so much. Good question. So, we need to get the next generation speak the same language. Here in the back, please, one question.
Okay, thank you. Hello, my name is Aya Jamal. I'm from Sudan, and here I'm representing the International Pharmaceutical Student Federation. I would like to thank you all for the very comprehensive description of the Health in All policy. And I really do think that this is a good approach for to serve the 2030 agenda. So my question to Dr. Abdullah, I know that there is a coordination forum, the Health Sector Partner Forum, that can be used as a tool to have all the sectors in one place and to have their ideas, and it can serve as a good tool for the Health in All policies. But I'm curious to know how you're actually planning to get this initiative function. Are we planning to have representatives from all sectors to be placed in one room maybe, and to have their ideas on this? Or because I know the initiative, we're advocating for the initiative now, but I'm not sure if we're actually functioning the initiative. Also, I want to take the chance while you're here and ask you if there is a room for youth to be actually engaged in the advocacy for this initiative, because I attended some side events the previous days, and it's all, there was like areas for youth engagement and youth programs, so I really do think that youth can be useful in the advocacy for this initiative in Sudan specifically. Thank you.
Thank you so much. We have here one last question, please.
Hi, my name is Nicole Pereira. I'm a graduate student from University of California, Los Angeles, with the Alliance for Health Promotion. Maria Nera noted the powerfulness and the impact of the local and the municipal level facilities. My question is directed to Abdallah Osman with regard to the functionality of the system at the national level and levels that are above the municipalities. You mentioned that they may have been impacted by or compromised, and I was wondering what the impact of that is on the higher levels above the municipalities and at the local level, and what strategies need to be in place to address this challenge. Thanks.
Thank you so much. So maybe I'll get back. I think there's something for all of you. May I start with Maria Nera, maybe, with the response? I'll do the reverse order.
Well, I think that they were very important questions here, and obviously there is not only one response. Everybody has to be involved in this approach, from the community to the local municipalities to the local global government. Obviously, we need to do a big work at the university and the training capacity. But I think the point is not, as I say, on training about health in all policies. It's training about the philosophy behind the health in all policies. So the case that Burema was describing about the communities, they don't need to train on a very specific approach, but understanding the co-benefits of the different policies and the different approach. That will be the one. Obviously, the new generation needs to be better prepared for understanding this primary prevention concept, which is very much about this intersectoriality, and it's about the fact that our population is getting old, and we will not be able to maintain the cost of the health systems, I mean, of the care. Even on those countries where universal health coverage is for free and is universal, like mine, this is non-sustainable. So something has to be done on bringing the resources for this primary prevention, and those resources need to come from other sectors and to be maintained.
Thank you, Maria. Abdallah, may I can pass to you? There were some questions directed to you.
Yes, thank you. I think concerning the local level and community, in fact, they not only understand, but they are doing it. But they don't name it health and all policy. This is what is it. Yeah, they are doing it. Then you need to make that in a systematic way, because this is the definition of the health and all. It is a systematic also issue. So what we are going to do is to systematize their work so that it can be enlarged. And concerning the operationalization, I think there are focal points from different sectors. But there are examples in the Ministry of Interior, for example. They took the issue of the road accidents. And they have their own structure inside the ministry, and they have their own follow-up measures, and they have a plan for that, and they bring, they issue reports regularly. Now, this is the third report which is coming out of the Ministry of Interior. There is something here very important. The Ministry of Health is not taking the lead. the lead is taken by the Ministry of Interior. And I think this is also a very good modality, so that you leave other sectors, they can move in the, and you make the overall leadership, not necessarily the specific leadership in the, for example, this case, road accidents.
Thank you. Thank you. Very good point also that actually other sectors need to take the lead on that. But Horacio, some reflections from your side, please.
Okay, first of all, I want to say, let's be careful to not transform in our policy like a religion, and we must be that way, okay? We are knowing better, understanding better how things go. It's a very complex issue in the society. We had health promotion chart in Ottawa. That was a kind of approach. Now we get a better understanding on social determinants and the way it is taken. All is how people take decisions for their environment and how they can take into account and think about their decision could have a good or a very bad impact in health. So you can do that by intuition. You can do that with a conceptual approach. But I think that's the way we must probably communicate, that understanding that when you work for the Ministry of the Family, the decision you're taking will have an influence on life. Even before a kid is born, the mother's health status will have an impact on this. So we work that with the others and their mission, and it's good that it's going to be them who are going to be the actors who are going to take it, not only health. And I think we should also work the social norm. I would just make an example. When I was in college, if somebody smoked besides me, I would just get out. I could not say, get out and everything. I would be punched. I was very small, and he was a big guy smoking. But now, we don't smoke anymore. When I go to France, it's for me incredible to see how much people are smoking in restaurants. We don't do that anymore in Quebec. So we are also using leaders, champions, not from health sectors, to promote healthy living, you know? So the norm, social norm is changing. The population is understanding, especially if they get good literacy, if we do communicate them to well, that even what they choose to eat, and we're also making the decision-making people not to say healthy living is only a own decision thing. We must have conditions to help healthy living. If you cannot walk outside in a good way, if you cannot only take your car to go somewhere, you are not walking. If we don't have new cities where you need a car to go even take a pint of milk, it's not good. You must walk. We must change the way our physical environmental is made. So I think that's a perspective why we should not be the only ones. People must ask for. It begins with the education of the population and also let the others understand the impact that is doing. Based on the revenu minimum guarantee, the minimal guarantee revenue, our Ministry of Solidarité in Quebec actually is making some studies, because that's probably, you know, it's expensive if we keep people in poverty. Those people are going to be sick, are going to ask for a lot of systems, and it's going to be very expensive for the social services. So getting employment, helping the ones who cannot, with a minimum revenue is probably a part of the solution. But that means a better distribution of the money in between different social groups. That's it. But that's things that we must think, because that's a cost to not invest in prevention. And we know in Quebec, we add 1.8% of the budget of the care system. So it's not even 2%. So I can tell you, I give you more health for my buck than the health you receive from a medication against cancer for perhaps give you 2 or 3 days more of life. That's the issue. And those technology are expensive. They are not good for everywhere. So I think youth are going to do better than we did based on what we learned. Don't do our mistakes. And I'm inviting you, there's going to be a meeting of the Association of Youths in Montreal in August. So if you want to have information, you're going to be the ones who make the change that will make me happy and retire seeing others doing the good job.
So it's actually nearly concluding remarks, but let me still come back to Virasek. Virasek, some questions also are to you, Som.
Just a few comments on the local implementations. From my experience, that in Thailand, for the health assembly or the health charter, not only the national implementation, we implement in the provincial or the regions, or even the sub-district level already. From my experience is that by methodology of the participation, we found the advantage of the implementation in the local level is the question of the representativeness of stakeholders. Because you are a small group, you can discuss, you can make more extensive dialogue any time because you had a small group. The degree of the engagement, because the question of the national level is the degree of engagement, who engage that one. But we found that in the local level, everybody engage in the decisions. The COI as well. The COI, somebody asked me about the COI conflict of interest between sector, but we found a little bit in the local level because their friend or family is there. From the implementation of the health in our policy that you guys say about they don't know about the health in policy, but for me, I think health in policy, the real health in policy is in the local for me. Why I say that? Because the comprehensive implementation is there, not in the cabinet, right? Why is that? Because everybody in the community, they affect to any decisions, to any factor in that village or the sub-district. There are no silo system there because you have to implement everything there. Yes, yes. And the health workforce as well. The mid-rank of health worker is there. There are participation from the village volunteer for that one. For me, I think the health policy, not only the national level, but in the local level, I think is the real one for my experience.
Thank you, Virasek. And last but not least, Taro, maybe some reflections from your side. There were also some specific questions to you. Please, the floor is yours.
Thank you. Very good questions from the audience. If I may start with terminology, language we are using. So I also hope that we are not in the future speaking about religion or health and all policies. We have found that it's perhaps more useful to speak about languages to others. For example, Ministry of Labour is speaking about workability. Or Minister of Interior is, for them, it's a feeling of security of people. And we are just speaking about the same issue. So it's easier that we are not just trying to speak about health and all policies, but try to speak so that it's opening what we are speaking about. So, and sometimes if we use the term, it's controversial, so it can create some criticism. So to find common words and common language is essential. And then about several issues about question concerning the role of the young people and how to create more understanding on importance of health and all policies. We have tried to create for all age groups, for all the population, understanding about health and well-being from the beginning of life already. And for example, while we are now part of a non-communicable diseases commission, the global level, which is trying to take up approach for implementation, we have promoted the development of health literacy. So that we could create already for children and for all age groups understanding what is health, what is well-being, and what we all can do for that. So if it's a common understanding and common knowledge, and so it's easier in a way to build on that already for all the professionals also, so that it's something which is useful for everyone. So that's something I would like to take up here. And of course, we also need to increase the ability of health professionals to understand what's health, really, not the disease. So that's something which is a challenge for us. It's not self-evident that we on our sector all understand what the benefits are or what's the value of health. So that, yeah. And then one question was about the basic income, which in Finland we have an experiment going on. It's very small scale compared to other countries. And we have some results already there, but it's only a couple of thousands people, so it's not very broad. But it seems that people are happy and satisfied with that kind of system. They don't have to apply for social benefits so often. But we don't know yet what are the results, or are we going to continue, how long that. But it seems that it could be useful. But I would like to raise here the issue that it's one part of a picture. You need something else also to promote the well-being of health of people, and you need their multi-sectoral approach. And we have very good results how social sector, health sector, and employment sector work together to find the ways for people for going back to the working life or finding a way of good life. So, for example, these three sectors, so that we all together can find the right services and the balance for people, so that it's not just the income. You need there some social support. Sometimes it's just a problem that people haven't got the health services or rehabilitation they need. So that all these together looking at the situation. So, yeah.
So thank you so much for all your reflections. Thank you to all the panelists for joining us here. So thanks a lot. So please, maybe you could come here. Yeah, maybe. So the event is not yet over, so bear with me for another 10 minutes. We started a little bit late, so we do want to still hear from Carmel Williams. Welcome, Carmel, from the government of South Australia. Of course, also a federal state, but very active in their right of having healthcare system organized at the provincial or the state level. And we talk here about tool, health in all policy as a tool, not as a religion. We talk about a tool that nobody should no one should be left behind. And of course, that's also health in all policy. And South Australia has actually published and collected different case studies around the world, published them also as progressing the SDGs through HiAP, through a HiAP approach. But there are also further plans on that. And Carmel, we'd like to hear from you a little bit on how you build on further.
Right. Thanks so much, Michaela. And I'd really like to acknowledge the great contribution from all of the panellists today. I think you probably will all agree with me that the panellists have really highlighted such a diverse and broad range of approaches to implement and address health and all policies. Each of the stories provided a bit of an insight into the way those countries and sub-national countries, or Quebec, for example, the culture and the governance structure, how much that's important to influence the way that the health and all policies approach is applied. And it's for this very reason that the Global Network on Health and all Policies has made the development and the gathering of information around global practice of health and all policies as a priority. So one of the things I'm going to be talking very briefly about, because I realise we're running out of time, is why we want a global status report on health and all policies, what it might be able to do for us, and how we're going to build on some of the global information that we have around health and all policies practice moving forward. So, first of all, why do we need a global status report? I think what we're really wanting to do as part of the Global Network on Health and all Policies is to set a bit of a baseline. We want to understand what is the depth and breadth of health and all policies practice operating across the globe. We understand that actually there is, as people have talked today, there are many people that are probably practicing health and all policies but aren't articulating it, don't recognise it. So we'd really like to start to tap in to those organisations and those communities where health and all policies practice is operating. I think for the network itself, we're interested to see whether this baseline might be able to help us think through whether this could be a measure of success of the advocacy and knowledge translation that the network has at its heart of aims and objectives. We're really wanting to stimulate and promote health and policies practice more broadly. I guess we're not religious about our beliefs, but I think there is a strong consensus amongst the members of the network that health and policies is an approach that is a very useful way of working to try to get common goals addressed and to sort of shape policy decisions, programs and service delivery in ways that are good for society as a whole, but also in particular that are good for health. And I think we really want to have the Global Status Report provide an opportunity for people and nations and subnations and cities, as we've been talking about today, to really understand how they can strengthen their practice, what bits work in what context, what bits aren't appropriate for certain kind of cultures and governance structures, so that we really sort of start to get a much richer, deeper understanding. But as Michaela's mentioned, we're not starting from scratch. The Global Status Report will build on there'll be many reports trying to describe action on the social determinants of health over a number of years, and health and policies has been incorporated as one of the strategies to use that's been incorporated into these case studies. More recently, there's been some work explicitly looking at health and policies practice as a primary strategy for addressing the Sustainable Development Goals, but also the social determinants of health. Last year, as part of an international meeting that Adelaide and the Government of held in Adelaide, that the Government of South Australia and the World Health Organisation facilitated, we put out a call through a number of networks to see what would come back in around for case studies on health and policies practice. So what was different about this call was we were very clear about putting some criteria in around what would be considered as health and policies. And that criteria included the need for there to be some governance arrangement that enables health and policies practice to operate. And also that it's not an issue-specific approach. So it's not like the work on tobacco, even though that's incredibly important. And we certainly have learnt so much from that, and we're not trying to undermine the fantastic work that happens in the tobacco field. But as an example, we're really wanting it to be multi-issue, multi-strategy, multi-departmental-based approaches. So that's what this case study book was about. And what was really interesting is that we got quite diverse range of cases. We got those that are emerging, that are new, that are just testing health and policies practice. We got those that have been really well established, that we're very fortunate to have Finland submit a case study, and there's so much to learn from Finland's experience. We also got stories from national countries, subnational states, such as Quebec, and South Australia has a case study in there as well. And there was a couple of cases that were submitted that were from cities. So at the municipal level. And so this is something that we're really wanting to build on. One of the things that the case study book doesn't do, it doesn't do an analysis around the different approaches. It's a descriptive document. And it's fantastic because we were involved in creating it, but it's not probably enough. So we really recognise we need to do more. This is just a brief example, and you can see that it's quite a broad reach. We were very lucky that we were able to get sort of representation from every region, but you can see that it's not very deep. There's many, many countries, many places missing, and that's one of the goals of the status report, is to try to fill those gaps. One of the other things that we did once the network was established, the steering committee members were really interested to find out what is health and policies practice amongst the members. Now, the members are a more diverse group than the case study authors were, although the case study authors also were included. And we were able to, we got 19 responses, and that stretched our breadth. We did the survey through a SurveyMonkey approach, and we drew on the experience in the case studies to help shape what the questions of the SurveyMonkey was. But again, 19 responses, 19 experiences we don't see as being enough. So, what we really want with the Global Status Report is we see this as a really timely opportunity for us to be able to collect global trends and to be able to analyse key themes around how health and policies practice is operating across the globe at the moment. it's really about the current state of play. So, and the report we aim to release at the end of this year or early next year. If I'm honest, it'll probably be early next year. But the critical bit is that we want to do an analysis. So the report's not intended to be a scorecard. We're not going to be trying to compare different health and health policies, experiences in different countries, because one of the things that we've learned, and I think our panellists made this really clear, is that health and health policies is so context and cultural specific that it's difficult to make meaningful comparisons and score different regions on their approach. But what we can do is we can learn about what's working. What are the common elements that seem to work across all jurisdictions, regardless of whether they're a city, a subnational or a country? And then what are some of the mechanisms and elements that might operate in some cultural contexts that don't operate in others? And in this way we can get a better insight into how we can support other jurisdictions to start to implement and promote and progress health and health policies practice as a strategy to achieve the Sustainable Development Goals and universal health coverage. So that's just letting you know some of our plans, and you know, hopefully you'll hear from us soon.
Thank you, Kamel. Thank you also for giving a little bit an overview of the activities which are planned with the Global Network, and we do look forward to the status report. We do look forward also to dig more into some of the topics. As you can see, we have just touched upon the first one out of the 8. So more to be said, and more to be analyzed, more to be shared, actually among us all. And I want to now just also call the Honourable Minister for the concluding remarks, and want before that just simply thank you all for coming to that lunch meeting, but also thank to all those who have been involved in preparing it, Nicole and Alex, especially from WHO, Sarah from our side, from the GSC side, Nanoot, and all the steering committee members for being regularly on calls and discussing on how we shall do this. So thank you all for coming. Thank you also to the panelists for sharing your experience and being so open to us. Maria Nera for coming and joining us. And with this, these are my concluding remarks, but they are not the final. The final word goes to the Minister. Please, Minister, if you could just have your final concluding remarks.
If you could give 2 minutes for the representative of Tunisia, because he raised...
Yes, of course, please.
Yes, okay.
Please, share with us your experience, just very short. You can also take from the pult if you want. Should work.
Okay, permit me to speak in French. My English isn't very fluent. Donc, je viens de la Tunisie, du ministère de la Santé. Je suis le chef de cabinet. Et on a bien sûr adhéré à ce programme à partir de l'année 2016. Et on est surtout le gouvernement après révolution, on est bien imbibé que les déterminants sociaux de la santé sont les facteurs essentiels dont la révolution a mis en exergue et a mis en premier lieu. C'est une redevabilité vis-à-vis à cette transition démocratique. Et pour cette raison, on est engagé sur le plan politique d'avoir cette approche de santé qu'on considère réellement une méthode de gouvernance de l'argent public, comme je viens d'entendre messieurs les panélistes. Et puisque aussi la gouvernance de l'argent public est l'une des demandes de la transition démocratique, ça renouvelle encore une fois notre engagement à adhérer à ce programme et être parmi les acteurs essentiels. Voici, merci.
Merci beaucoup. Merci aussi pour joindre nos efforts ici avec le Global Network of Health and Health Policy. There is no translation. Switzerland works bilingually in this institute as well, so my apologies. Honourable Minister, the concluding remarks. Thank you so much.
Okay, Michaela, thank you. We have seen the different experiences from the different countries, and really we found how the health and all policies is very important, and the health and all policies is important not because only even economically development. You know that healthy people, not ethically, and it is the responsibility of the country to provide health for the people, but also if we want the economic and the development, we need to invest in the health. I think that is very important. Sometimes the people of the Ministry of Finance do not understand that. Now, gradually getting to understand that, that is one of the crucial issues I think that's important. The second thing is we found also we cannot achieve health policies unless we have a strong political commitment and a strong leadership in the different levels, because this is the issue that we bring all the stakeholders or different ministries, different sectors, and even civil societies, private sectors. So that is you cannot bring them unless you have either the top political leadership political commitment, or the leadership in the different levels. So I think when we say that, that means you can allocate more money for the health. That means also you can bring all the sector together. That means you can set the priorities and health to be center of the priorities. This is why we think all the leaders in the different countries and the organization need to bring this concept from the theory to the practice. And that now we start seeing in different countries. For example, in Sudan, just 2 weeks ago, we have the meeting of the overall health sector, including the different state health ministries. You know, by the way, now we have 2 of them here. Zainab from Zainab, stand up. Zainab is the health minister of West Kordofan, and Mohammed Yusuf. Mohammed not around. There's Mohammed in the group A, committee A. He's the health minister of West Darfur. You know, in that meeting, we discovered that the concept really gradually transferring from the theory to the practice, because one of the wonderful reports that received in that meeting is in Sennar state. This is one of the 18th states in Sudan. Even they go deeply to the community-oriented. In the villages, they establish committees, including the religious people, the women, the youth, the students, all the people in one committee talking about the health issues and the health in all policies. Health cannot achieve, it's a cross-cutting issue. You need to take everybody on board. I think that is, things are now moving in Sudan, as I see, and also I hear from the different countries and the panelists, we hear that I think we need to exert a lot of efforts, but it is now going forward. Let me, at the end, I thank really the members of the steering committee and the members of the network of the health and all policies, and also the co-sponsoring countries, and the Global Center for the Global Health Centre at the Graduate Institute, Michaela, special thanks for the center, because this is the second time, respectively, hosting this event. And also, I think today the participation of Maria, she is the director of the public health and environmental and the social determinants in WHO. This is why her comments really goes to the real issues that we are talking about, whether we mention it or not. I think, thank you for coming, Maria, and we hope WHO can play. Nicole had been engaged in this issue since the starting, and now you came today So next time also bring with you Dr. Tedros, and with yeah, I think that's very important because the role of the WHO is actually crucial. Also, let me thank all the panelists, participants from the different countries, from Thailand, from Finland, from WHO, from Sudan, from Quebec, Canada, Aroda. Really, you participating. Okay. And before I conclude, I thank Carmel for the wonderful presentation, and Michaela for the wonderful moderating the side event, and we hope the next year we can arrange these side events and more people can attend, participate in this side event, and also we can present the progress that we are always doing. More countries and organizations can join the network. Thank you so much.
Shukran.